Welcome to the ERA Journal Club for today. I am Dr. Jennifer Lees, Clinical Lecturer in Nephrology at the University of Glasgow, and delighted to introduce the topic of the Journal Club for today. So this will be the induction and maintenance of remission with mycophenolate mofetil in ANCA-associated vasculitis, a systematic review and meta-analysis. So I'm very pleased to introduce two speakers and two expert panelists today. Our two speakers, Dr. Andreas Kronbichler is a consultant nephrologist and senior research associate at the University of Cambridge, interested in vasculitis and glomerulonephritis, and is a member of the ERA's Immunonephrology Working Group and Young Nephrologist Platform. And Dr. Alvise Berti is a consultant in the rheumatology unit and PhD student in Trento, Italy, and a fellow of the Vasculitis Clinical Research Consortium at the Mayo Clinic. Our two expert panelists today are Dr. Rachel Jones, who is a consultant in nephrology and vasculitis at Addenbrooke's Hospital in Cambridge, a member of the European Vasculitis Society, and has played a pivotal role in many of the major vasculitis trials. And Professor Annette Bruchfeld is a professor of nephrology working between Linköping University and the Karolinska Institute, and is the chair of the ERA's Immunonephrology Working Group. Delighted to present today alongside my friend and co-moderator, Dr. Kate Stevens, who's a consultant nephrologist at the Glasgow Renal and Transplant Unit with an interest in vasculitis, and she's also a member of the ERA's Immunonephrology Working Group. A little bit of housekeeping. If you would like to send any questions in for our speakers or panelists, if you use the Q&A function on the seminar, we'll be able to pick these up and read them out to our speakers. And without further ado, I'd like to hand over to Dr. Kronbichler, who's going to start the discussion today.
So here we go. So thank you, Jennifer, for the nice introduction. It's a great pleasure, and we are really excited, Alvise and myself, to present today our data we have gathered. And of course, we are very thankful that the NDT has accepted our paper for publication. We are very happy and keen to move forward here. So these are our disclosures. Basically, we have not received money for this work from pharmaceutical companies. So Alvise and I are basically neighbors. He's Italian, I'm Austrian, and this is a lake actually close to the Austrian-Italian border. In 1950, a couple of villages were flooded, and this church tower is the remaining relic of that. It's quite beautiful there. This day when I took the picture, was quite cold and was snowing intermittently, so not really the best view. Coming to the topic of our presentation, we have worked about mycophenolate mofetil in ANCA-associated vasculitis, and we know that mycophenolate mofetil is very effective in reduction of transplant rejection, and it works quite well on T cells, as we see here in this slide. But what we have understood in the COVID-19 pandemic, and especially coming up with vaccinations, that it's also working on B cells, as patients receiving mycophenolic acid or MMF have an impaired vaccination response in terms of humoral response and antibody response. It's different to other treatment we are using in ANCA vasculitis, such as cyclophosphamide, which works on DNA synthesis. And you know that rituximab is quite an effective treatment in ANCA vasculitis, and it works quite well on CD20 cells. It's usually similarly effective across three different diseases, as azathioprine, which also has a profound effect on T cells. So most of the ANCA vasculitis studies were basically relying on data we had on mycophenolate mofetil in lupus nephritis. And here is an example of a phase 3 trial conducted internationally And this was based on a phase 2 trial published in 2005 in the New England Journal of Medicine, where they showed that in this phase 2 trial, mycophenolate mofetil was more effective than cyclophosphamide. In this international trial, this couldn't be confirmed. As you can see here, in comparison to intravenous cyclophosphamide, mycophenolate mofetil led to a response rate of 56.2% in comparison to 53% in the cyclophosphamide group. There are, however, subgroups of patients who will benefit of mycophenolate, here summarized in the other group, non-Caucasians and non-Asian populations. The response rate was, as you can see here on the right side, and the primary endpoint was UPCR reduction below 3 grams if patients were nephrotic, or they had over 50% reduction if subnephrotic. Importantly, the dose of mycophenolate mofetil in this trial was 2.6 grams, so many of these patients had a very high dose of mycophenolate mofetil treatment. If you look at the MyCyc trial, which basically compared cyclophosphamide against mycophenolate, similarly to the Armstrong lupus nephritis, Rachel Jones and colleagues included 140 patients, and they looked at remission rate at 6 months as the primary endpoint. The primary endpoint was defined as an absence of disease activity, usually defined as a BVAS of 0 and a compliance with a steroid taper. And you see on the left side in the figure that the remission rates were comparable between the mycophenolate group in blue and the cyclophosphamide group in red. If you look at the right side, looking at relapses, which is also a very relevant outcome in ANCA vasculitis, the MMF group had significantly more relapses during follow-up, and this was primarily driven by BR3 ANCA positive patients who we know that relapse more frequently. If you look at the dosing of mycophenolate mofetil in this study, you can see that most of the patients had 2 grams, which we use in clinical practice a lot, so almost 76% had this dosage, but also 18% had dosage of below 2 grams. Patients were allowed to receive more than 2 grams or increase in dose to 3 grams if they had a suboptimal response by week 4 during their induction therapy. Moving on to maintenance therapy, again, coming back to lupus nephritis as our role model, there has been the ARMS trial, maintenance trial, randomizing patients, 227 patients, either to mycophenolate mofetil or to azathioprine. And the authors found that MMF is clearly the better treatment in the maintenance phase in lupus nephritis with a significant reduction of relapses during follow-up. If you look on the right side, the side effects of treatment, they were quite comparable. Non-significantly less side effects actually with mycophenolate mofetil in comparison to azathioprine here in red. Surprisingly, this trial, the IMPROVE trial in ANCA vasculitis, was designed that mycophenolate mofetil is superior to azathioprine in the maintenance phase of ANCA vasculitis. Thomas Heemstra and colleagues included 156 patients and had a follow-up of over 3 years, 39 months. Azathioprine was used up to 2 milligrams per kilogram body weight versus mycophenolate mofetil up to 2 grams per day. The prednisolone starting dose in the remission phase, 15 milligrams, tapered to 5 milligrams after 12 months, and withdrawn if possible after 24 months. As you can see, not only mycophenolate was not superior compared to azathioprine, the authors found that MMF group had more relapses in comparison to azathioprine, and this was even significant. If you look at a relevant outcome, and that is clearly major relapse in this population, there was a non-significant trend to more major relapses in the mycophenolate mofetil group. But, and this is important, baseline characteristics in these trials were not balanced. Patients with ANCA vasculitis often have subclinical inflammation, but these patients are also prone to more relapses during follow-up. So at the time of remission or predefined remission, when patients were randomized, those in the mycophenolate mofetil group had a higher C-reactive protein. As you can see here, it was significant, and also a tendency to more or higher erythrocyte sedimentation rate. So this might actually argue that these patients were more prone to relapse during their follow-up period. And also more patients in the mycophenolate group were BR3 ANCA positive. And as you have heard before, BR3 ANCA positivity is usually associated with more relapses during follow-up. Looking at the definition of major relapses and minor relapses, there are also some problems in my eyes, because sometimes it's quite difficult to assess, for instance, if patients have a progressive subglottic or bronchial stenosis, here highlighted with the blue arrow. And of course, sometimes you're not performing thorough CD or other investigations at baseline, so you don't really know if the patient had, for instance, pulmonary granulomata at baseline. And if we scan the patient the first time and you detect lung lesions, you might classify the patients to have a major relapse. So this might really be a bit of a problem in such a trial. If you look at the relapses in detail, 30 patients in the azathioprine group relapsed on the right side, 42 patients in the mycophenolate group relapsed. And if you look at the kind of relapses, so around 40% had renal relapses, around 20% in both groups had lung relapses. Some patients in the mycophenolate group had neurologic relapses. And again, the ENT relapses were quite balanced in both groups. And with this, I would like to hand over to my co-presenter, Alvise Berti, for further discussions.
I'm going to talk about the methods and the results of our trial, of our study. As mentioned, we perform a systematic review and a meta-analysis of the phase 2 and phase 3 trial assessing the mycophenolate mofetil efficacy in AAV, which means granulomatosis with polyangiitis and microscopic polyangiitis. We perform a systematic review, so we search several databases from inception to May 5, 2020, and we extracted the data to compute odds ratio and estimates for MMF efficacy for both induction of remission and maintenance of remission. And of course, we also collected severe adverse effects and reported this data as well. So you can see here on the right the flow diagram for the inclusion and the exclusion of the study. We started from 565 studies, and at the end of the selection process, about 10 studies. You can see here on the right part of the slide the selection process, the flow chart for inclusion and exclusion of the studies. We ended up with 10 studies, and you can see that we collected the results of 5 phase 3 studies, randomized control trial, and 5 phase 2 trials assessing the efficacy and safety of MMF. 4 of them assessed induction of remission, 3 of them assessed maintenance of remission, and 3 of them assessed both. The intervention arm used MMF as the main agent. As you can imagine, there were differences in the trial designs and in the patient features among these different trials. And we are going to talk about this in a second here. As you can see from this table, there are different follow-up times of the different trials, especially for remission maintenance. But I'd like you to focus your attention on the MMF dose. Most of the trials use 2 grams per day, but as you can see, there was some difference in some protocols. Some of the trials allowed to increase the dose up to 3 grams per day. In some other cases, a reduction based on the body weight was allowed by the protocols, but usually the cutoff was not exactly the same. Anyway, most of the trials used 2 grams per day as the study regimen of mycophenolate. For the phase 3 trials, cyclophosphamide was used as the main comparator. Both intravenous and oral. And for the only phase 3 trial for the maintenance of remission, azathioprine was used as the main comparator. So as mentioned, we observe really different baseline features among the different trials. I like you to focus on these 4, since these are very important for the meta-analysis that we performed. As you can see, several trials enrolled only patients with renal manifestation, 100% of renal manifestation, and other trials enrolled patients with and without renal disease. Then in some trials, only patients with a diagnosis, with a clinical diagnosis of MPA were enrolled, like the Francisco Silva trial or the Han and colleagues trial, whereas other trials enrolled only patients with a GPA diagnosis. And in some cases, both GPA and MPA patients were enrolled. In some cases, only patients with MPO ANCA positivity were enrolled, as in the case of Silva, again, or in other cases, patients with PR3 positivity, MPO positivity, MPO ANCA positivity, PR3 ANCA positivity, and in some cases, ANCA negative patients were enrolled. But let's focus a little bit with a lot of heterogeneity in between the different features. But let's focus on the renal disease in particular. So as mentioned, different trials had different proportion of patients with kidney disease, with kidney involvement, but importantly, different trials have different patients with different kidney disease severity as measured by the level of serum creatinine. As you can see, the trial of Hu and Han, for instance, have higher levels of serum creatinine and a quite high level of proteinuria in the 24 hours, whereas other trial has lower level of the creatinine. And in addition, in some cases, creatinine was measured by in micromole per liter, in some other cases in milligram per deciliter. In other cases, only eGFR was reported and not the creatinine. So to make a long story short, it wasn't possible to compare the severity of the renal disease because of all these differences. But let's go to the meta-analysis and to the results, the main results of our study. So you can see here the 4 phase 3 trials for the induction of remission. And in these 4 trials, as I mentioned, the efficacy of mycophenolate was compared to that one of cyclophosphamide. So you can see here that when we pull together all the results of these 4 trials, the odds ratio is 1.06, so reflecting the absence of difference in between the 2 arms for the induction of remission. Then we tried to subgroup the outcome by renal involvement, separating those trials, enrolling 100% of the patient with renal involvement from those enrolling patient with and without renal involvement. And as you can see, the odds ratio for the first group here, the one with renal involvement, with 100% of renal involvement, was 1.4 as compared to 0.97 for those patients with and without, for those trials with and without renal involvement. But the difference was not statistically significant. Then we pulled together phase 2 trial and phase 3 trial, and we calculated the estimates, which correspond to the proportion of the patient in remission, getting remission or achieving remission. And so essentially we pulled together the phase 2 trials, which are single arm, and the experimental arm of the phase 3 trials assessing induction of remission. And as you can see, again, we stratify by renal involvement. And again, the difference was not statistically significant between these 2 groups. We then wanted to measure the maintenance of remission efficacy for mycophenolate. Just as a reminder, as Andreas mentioned before, we have only a single phase 3 trial assessing mycophenolate in maintenance of remission, and this is the IMPROVE trial, Thomas Jensra here. And then we have several phase 2 trials. The 2 trials actually assessing specifically maintenance of remission, Langford and Novak, and other 3 trials measuring the induction of remission and the maintenance of remission with mycophenolate, but only one of them clearly separated the phase of induction of remission from the phase of remission maintenance, and therefore we performed here 2 different analyses, 2 different sensitivity analyses to make sure that what we were observing was really right. So in the left part of the screen here, you can see the estimation, the estimates for mycophenolate, and you can see, and again, we separated the outcome by those trial enrolling 100% of the patients with renal involvement from those trial enrolling patients with and without renal involvement. And we can see that there is a significant difference between these 2 groups with an estimate of 0.92 for those trial enrolling 100% of patients with renal disease and 0.56 for the others. And the sensitivity analysis, including the other 2 trials, not clearly separating the induction of remission and the maintenance of remission, actually confirm the same results. We then also wanted to make sure that the heterogeneity that were explained in our case by the renal involvement was not casual. So we did other subgroup analysis with other patient features at baseline, and we essentially repeated the same analysis for the induction of remission and the remission maintenance that I just explained, but stratifying the outcome by other features, so namely clinical diagnosis. So essentially we separated all the patients with a diagnosis, all the trials enrolling patients, only patients with an MPA diagnosis as compared to those trial enrolling patients with MPA and GPA. And we didn't see any difference for both induction of remission and remission maintenance. Then we stratified the outcome for ANCA type, namely comparing those MPO ANCA positive patients, trial enrolling 100% of patients MPO ANCA positive as compared to trial enrolling patient MPO ANCA positive, MPO3 ANCA positive, and some ANCA negative patients. And we didn't see any difference. And then we did the same with new diagnosis, comparing those trial enrolling only newly diagnosed patients to those trial comparing newly diagnosed and relapsing patients. And again, we didn't see any difference. So we finally had a look on the safety results, and we actually collected all the severe adverse outcome that were reported in the trial during the observation time. And by compiling this descriptive data, we observed that about 1/3 of patients reported at least 1 severe adverse event during the observation time, with severe infection, the most frequent one, 28.7%, especially sepsis and pneumonia was reported, followed by gastrointestinal events, 21.6%, and by leukopenia, 9.2%. So in GPA and MPA, mycophenolate use is significantly associated with higher sustained remission rates in the trials enrolling 100% of patients with kidney involvement. So, as a consequence, mycophenolate might be considered as an option for maintenance of remission in this subset of patients with kidney involvement in ANCA-associated vasculitis, whereas for induction of remission of GPA and MPA, MMF could be considered as an alternative option to standard medication regardless of the kidney involvement. But of course, our analysis have several limitations. I will just go quickly through them, and then I will leave them as for discussion. So of course, we indeed did have a small sample size to compare. All the trial that we pulled together have different inclusion criteria, as I explained a little bit at the beginning, with a lot of heterogeneity. Most of the trials excluded patients with life-threatening disease. And then, of course, glucocorticoid dose and tapering during the follow-up were heterogeneous and unclear, and making so very difficult to compare them, if not impossible. Of course, for the remission maintenance, we didn't have a lot of high quality studies, just a single phase 3 study, as mentioned by Andreas, with some caveats, and our results was based mainly on phase 2 trials, which when you have to balance the quality of the study, of course, a phase 2 trial is less high quality as compared to our phase 3 trials. And finally, of course, our results put together the results already published on MMS in ANCA-associated vasculitis, but of course, we cannot create new evidence. We just summarize the actual evidence present in the literature. So which is the practical message for the clinical nephrologist? Of course, mycophenolate remains a second line agent for ANCA-associated vasculitis. That's known, but it is still used in some patients with AAV. I bet that several of the physicians listening to us have at least a few patients on mycophenolate, but there is not a lot of evidence. We just observe. And the contribution of this meta-analysis and systematic review is that a patient with kidney involvement may benefit more from the use of mycophenolate as compared to the others. So, of course, this is an ongoing process. We are still looking for the right spot to look at the evidence in mycophenolate in AAV, but it is still an ongoing process. And therefore, we are happy to take any question and to discuss this. Thank you so much for your attention.
Thank you to you both for a very clear and very succinct run through of mycophenolate's position in the treatment of ANCA vasculitis. Your last slide was very clear, highlighting the difficulties in terms of the population that you're trying to look at, particularly things like PR3 and PO positivity, and whether or not they have major organ involvement. So I just want to start off with a question to all four of you, if that's okay. I'm going to ask you the same question. So you've said in your presentation that mycophenolate is a second-line agent for vasculitis. So Rachel, I'm going to come to you first, just because you're first on my screen. Under what circumstances would you consider using mycophenolate in your clinical practice in ANCA vasculitis?
Okay, well, thank you both for the lovely presentations. I mean, I would argue that it's actually third line. We have cyclophosphamide and rituximab. So now I think it's very difficult when you're doing a meta-analysis. I appreciate this to get into very subtle differences in trial design. And particularly that point about the MPO versus PR3, your data seemed to suggest there wasn't a big difference when looking at results in a meta-analysis setting. I can only speak from my detailed experience with the MySite trial when there were clearly more relapses in the PR3 group. Now that was azathioprine in both groups, but this is reflecting in impact of induction on sustained remission, I suppose. I also know there's been a very recent ANCA subtype analysis of the IMPROVE study published in abstract format only, which has shown PR3 relapses were much higher in IMPROVE in the mycophenolate arm, but very different, very similar with the MPO subtype between mycophenolate and cyclophosphamide in the IMPROVE study. So these two bits of evidence now make me really, really nervous about prescribing it for people with PR3 ANCA vasculitis, because we're not just talking about getting them into remission, we're talking about keeping them in remission. Second thing I would say is in the MySite trial, and this was one of, Alvise highlighted this as a limitation, the steroid doses were quite high in the induction phase. And the vogue today in terms of ANCA vasculitis treatment is very much moving away from high dose steroids. So what the danger is that where we've got studies that present mycophenolate as a potential treatment option as an alternative to cyclophosphamide, where high dose steroids were used, including IV methylprednisolone, 1 milligram per kilogram starting dose orally prednisolone, if we extrapolate that and still use the more modern sort of lower dose regimens, we may be using it in a slightly unevidence-based scenario. So that's just something to be really mindful of when using this drug. Certainly the MySite trial had quite high prednisolone doses. I'm not sure about all the other studies, the prednisolone doses. So that is a really sort of important point you raised. So I would use it, in answer to your question, in patients with MPO ANCA vasculitis, where there were low risk of relapse. I would use it when cyclophosphamide and potentially rituximab were contraindicated, where there wasn't life-threatening disease manifestations, and where I'm prepared to use relatively high doses of steroids. So those criteria narrow down the use of this drug quite a lot. Nevertheless, it's great to have it in our, at our availability. I will let others comment as well.
Okay, thanks, Rachel. That was really helpful. Annette, you next.
Yes. Okay. So Rachel took all my points. No, but so I think one of the major problems here with mycophenolate is because this dosing, we don't really know the dose, what gets into the patient. I mean, we do have the option to do therapeutic drug monitoring, but that was never done in any studies. So what concentrate? I saw one of the questions actually that was pretty good from. In the Q&A about drugs that can interfere with the MMF levels. That I don't know if you can find that data in the MyPsych trial. That would be quite interesting. Do the patients actually get the same dose? We don't know that. And I just wanted to share what happened to all my patients. I had 8 patients in the MyPsych trial because I was thinking of that. What do we do in the maintenance phase so we can induce remission? That's fine. But all the patients who were PR3 ANCA positive, over the years, they all ended up on rituximab if they had a relapse eventually. So I think in a low risk population, MPA positive, these type of patients, where you think you have to take care of, you don't have to be too afraid of a very dramatic disease or you can use MMF, but since the problem is that we have rituximab now, and that is our first or second alternative, I would say. And in the end, I mean, there would have to be an MMF versus rituximab trial, and I don't think that will ever happen. But if we would do a trial again with MMF, I think it would be really important to do therapeutic drug monitoring. To know what we're doing.
Yeah, and actually, so just before I come over to the boys, ladies first, just out of interest, so we don't monitor levels in our centre. We can't monitor levels in our centre. What happens in Cambridge, Rachel? Can you monitor levels?
Not easily, because we send them to a different hospital, so we don't get quick results. In answer to Annette's point, we have got MPA levels from the MyPsych trial. We haven't actually ever published those, so I mean, it's something that I've, particularly when I saw this improved data recently, I did think that it's something that we really need to get back to and look into in detail. Yeah, so, and that may, I think the truth is that MPA monitoring is not very accurate. We know this across different disease areas, including transplantation. I personally in clinical practice find it very useful to check for compliance, so extremes of results. So and also people who've got very significant side effects, if they've got a very high level, that reassures me that they're probably receiving an inadequate dose, even at a dose that may be less than 2 grams. So I find it useful for the extremes, but not for the sort of tweaking small dose increments. But that's my personal experience.
Yeah. And I just want to about the hospitals I work at, we can do the MMF area under the curve pretty easily, and I use it quite a lot exactly for that purpose. But we use it more in transplant than in vasculitis, actually. But I would say that I think the improved trial was kind of strange. I always thought that the tapering of MMF, it was tapered, but azathioprine was never tapered. So I don't know really what we compare there, but I would like other people perhaps to comment. on that.
Okay, so let me just put the initial question. So Andreas, first of all, do you have anything to add to what Rachel and Annette have said in terms of when you would use mycophenolate?
Yeah, I just want to clarify. Second line was meant, rituximab and cyclophosphamide are our first line treatment, and then MMF as second line treatment. I think Rachel basically answered everything. I just wanted to go back because in our discussion we were quite clear that there is good data for MMF in ANCA vasculitis and lupus, especially when patients achieved a certain trough level measured. But then, of course, there is the difficulty that the level is not really stable if you just measure it once. I think you would need to measure it constantly. But Irmi Neumann has shown that if you reach a certain trough level and you're not going above, your risk is not really that high to get severe infections, but efficacy is better. So I think if you want to use it, and especially in a critical patient, you would probably need to go and measure trough level if you want to make sure that the patient has enough in a dosage range. Dosage in lupus nephritis is way higher, and the patients are usually looking different. So a general lupus nephritis patient is usually female with 50 to 70 kilograms. And our AAV patients are usually men, most of them are men, and have over 100 kilograms. So I think, not only we are dosing it lower, but also the population is a different one we are treating here. And in maintenance phase, it's clearly a different story. Rituximab is clearly number one, and then we have azathioprine, and for non-nephrologists, we have methotrexate, and I think in the third line, we have mycophenolate mofetil. That's it basically for me.
And in terms, so you mentioned dosing. So in terms of the dose, if you were to use this under very specific circumstances, so if there was reasonable amounts of steroid, the patient was MPO positive, what dose of mycophenolate would you be aiming for?
So I think, the point of Rachel mentioning steroid doses have changed is a very valid one. I've not used mycophenolate for ages in AAV, to be very fair. I think it's, the convenience to treat a patient with rituximab is so high. And giving patients 3 grams of mycophenolate would mean that you increase the pill burden by 6 tablets a day. So the difference alone here is really huge. And even in light of the pandemic, even though rituximab has all these adverse events, but you treat them and you just send them home and they are doing well. While if you give them mycophenolate mofetil, you will need to bring them back to the clinic more often. So I think even this is not really a valid good reason to prescribe mycophenolate here. But if you treat them, I think you need to check dosage quite frequently, and you need to go up eventually to 3 grams.
Okay, so similar to lupus, you'd be aiming for 3
Yeah.
grams. Okay, I think, my experience would be that often patients are not on as high doses as that, which may be part of the issue. So Alvise, I've come to you last. I think the others have answered that point succinctly. Is there anything else you'd like to pass comment on in terms of when you would use mycophenolate?
Yeah, it's very difficult to speak at the end of
I know, I'm sorry,
all the others, but not kidding. But yeah, just a couple of points. Of course, I can just agree with the panelists about allocation of mycophenolate and the position. Of course, the position, the first, second, and third line. Of course, that's also what I do in my practice. Just wanted to touch a couple of points. The one is the different ANCA type that Rachel Jones was mentioning. I agree actually that there are evidence out there that ANCA type could also influence the results, but what we observe in our meta-analysis is that we didn't see any. Of course, this might have been a problem of sample size and numbers. That's true. There are not so many trials out there on mycophenolate with not big, huge, large trials, and that might have been a reason. But anyway, it's important to mention that the ANCA type, the clinical diagnosis, and the newly diagnosed versus the relapsing disease, these three are three non-independent features increasing the relapse risk during the follow-up. So for sure, it's important to control the three of them and the renal involvement eventually before to decide which kind of drug to use on a patient. Regarding the rituximab, I 100% agree. I just wanted to mention, for the sake of completeness, that these studies started during the idea of this trial started during the first wave of pandemic. So everybody was scared about using rituximab in these patients. So there was a need to see which other drugs could be safe but still effective in patients with AAV. So that's why we tried to understand if mycophenolate could have a role. And of course, then now with Omicron, things change fortunately a little bit. Probably the mortality and prolonged positivity is a little bit less. So there are also these to be considered, actually. In my practice, I usually use mycophenolate as a second or third line, usually with patients with renal disease, but with mild disease, if possible, and for maintenance. I never use it for induction, honestly.
Okay, thank you. So those answers I think were very helpful. So this has generated a lot of discussion, which is great. We've got some questions that were submitted in advance, and we've got questions in the Q&A. So I want to quickly just come back to Annette's point, because I'm aware that you wanted your question answered regarding tapering. So azathioprine and mycophenolate. Who do you want to answer that, Annette? Do you want Rachel to answer it?
I don't know who's, but Rachel wasn't responsible for improve, but I always thought that that was kind of a strange concept. I don't know if there were any discussions about that when you picked the doses for that you wanted to continue on this steady high dose during the induction trial and not do anything else, because in the improve trial they did taper MMF, so it was 1 gram at the end. And they kept the same azathioprine dose, which I never understood that.
Shall I comment on that?
Yes, yeah.
I mean, I completely agree with you, Annette. I think in clinical trials, you've got to kind of compare like for like, and or at least, you know, stick with the same dose. So it is questionable. I mean, there are other precedents in other trials for sort of tapering doses, for example, in the withdrawal study. Gosh, the name's gone out of my head. What's the withdrawal?
The Remain.
The Remain.
No, the Remain, yeah.
Yeah, the Remain study. So and it reflects clinical practice, what we do. So I can see why at the time that it was designed, you know, that we tapered the dose, but it's very then difficult to compare it directly with the azathioprine, and what is the same azathioprine dose compared to a tapering MMF. I don't know. The only other comment I had about dose is the need to start it quickly and build the dose up quickly. An issue in clinical practice is if you're changing between your remission induction agent and your remission maintenance agent, there shouldn't be a gap in immunosuppression. Now, in clinical practice, we're very used to giving rituximab or cyclophosphamide, which clearly have long duration of action. So we have time to build up the azathioprine dose or time to build up the mycophenolate dose. But if you're using mycophenolate as an induction agent, it's a twice daily drug. As soon as you stop it, it's more or less wearing off. So you can't then afford to spend 2 to 3 weeks building up your dose of your next drug, whether it's azathioprine or whatever. That's a really important point, and that can be a chance for patients to lose their disease control and relapse. And I think that's what we saw in MyPsych. There was a big separation of relapse curve early, possibly because people were slow to build up the azathioprine dose. I also think when you start it from remission induction, mycophenolate, I mean, you should be building up the dose very quickly. And that's what we try to do in the protocol in MyPsych. If you are using it for remission induction, it shouldn't be over 4 weeks you build up the dose. I mean, that's not what we do in ANCA-vasculitis, is that we have to, slightly different to perhaps lupus, where you may go in a bit slower, but you've got to start it and build up the dose quickly.
Yeah, thank you.
Yeah.
Very good point. So I'm going to now just answer some of the questions that we've had put to us. So Alvise, I'm going to come to you first, give you a chance. So if you were using mycophenolate, when would you decide that it was not working and shift to another agent?
Oh, okay. Well, I mean, I can answer just considering that in most of the cases I use it as a maintenance agent. Well, actually, of course, when I see some kind of sign of relapse or that might suggest relapse, and usually since I kind of use in patient with renal disease is kind of straightforward. So when you see an increase of the creatinine, maybe with some proteinuria, you know better than me actually, some hematuria. But yeah, that's usually when I decided to use it. It might be different probably, and this question might be better answered when you consider in the induction of remission, because there might be some period of time before mycophenolates start to have an activity. And probably this is very linked with the glucocorticoid dosage to some extent. So probably the nephrologist here, I'm not a nephrologist myself, but probably the nephrologist here will be more happy to answer this. But I do believe that this might really be linked to how many glucocorticoid you use for induction of remission. And since things after Paxivas are changing, this is a really an open topic to be discussed.
Yeah. Okay, so in the interest of time, I'm not going to go around you all, but Rachel, you've got your hand up. Would you like to say something?
It's just coming back to your findings of perhaps improved efficacy in renal disease. I just wanted to mention this very old trial that we did in Cambridge called MyPsych, which was a very heterogeneous population and not purely ANCA vasculitis, but it was multisystem autoimmune disease patients. But we found that the sort of toxicity was greater in patients with renal disease, and I really do think there is an accumulation of MPA and its metabolites, and probably in more advanced kidney patients with advanced kidney failure, you do get a higher MPA exposure. Now I don't know if that sort of, you don't have that level of detail for your meta-analysis, do you? But, you know, I do think some of the reason that mycophenolate may be more effective in people with lower GFRs might be because they're just getting more of the drug. Of course, there may be other reasons as well. It's got an antifibrotic component to its action. So, but it's just a thought. So dose may be very important, and exposure to MPA may be very important.
So that's where measuring levels would be useful, isn't it? So that actually leads quite nicely onto a question from Serhan Tugler, who's asked, or she said, she's commented, thank you for presenting this article. So I'm putting this to you, Andreas. And she's asking if you looked at the severity of renal involvement. So for example, the need for kidney replacement therapy at the time of diagnosis.
So these patients were usually excluded from these trials. And as Alvise mentioned, in this other table, we have summarized basically the starting creatinine. And clearly the Chinese articles with renal involvement, they had a higher starting creatinine of around 3 milligrams per deciliter. And as Rachel mentioned, I mean, this is probably one of the reasons why these patients did better. Maybe their mycophenolic acid level, the trough level was higher, or these patients also don't have that high of a relapse risk, especially MPO ANCA positive with a severe kidney disease at baseline.
So then that also leads nicely, you're doing very well here leading through these questions, to a question from Dr. Nessam, who's wondering, is there a cutoff creatinine level or GFR that would favour the use of cyclophosphamide versus mycophenolate? Yeah,
it's pretty much the same as with rituximab, I would say, because it's untested in GFR below 15. And the same is basically true for rituximab monotherapy, because the RAVE trial has excluded these patients. So there is limited evidence that these drugs can be used. For rituximab, we have some evidence from Paxivas that it's probably effective, but we need to wait for these data. And so for GFR below 15, I think cyclophosphamide is still the preferred agent, or a combination of rituximab plus cyclophosphamide, plus minus plus max change.
Yeah, so yeah, I'm going to ask you about plasma exchange at the end, because I can't not, and we've had questions about it. That's going to be your your exit question. So Annette, what do you think about mixed regimens? So rituximab and mycophenolate, cyclophosphamide and mycophenolate for induction maintenance.
Yeah, so there is no really evidence of rituximab and MF. So I'm a nephrologist, and I'm always worried about the infection complications, whereas I find that some of my rheumatology colleagues are less worried. But perhaps we're looking at different populations. So these combinations, sometimes when we use rituximab, so in some rheumatologists, they keep the patients on MMF, or they keep them on methotrexate and things like that, which I would be hesitant to do that, because I think it will add to a higher infection risk. I think you have to choose your treatment carefully. But then there is this, I think, pretty good data on the combination of rituximab and cyclophosphamide, trying to avoid glucocorticoids, and it's nothing we do regularly, but we can do that. I mean, based on the data from the UK, for instance. But I have never combined rituximab and MMF for induction. That is not my experience.
Yeah, so lots of head nodding from the other panelists. So an advanced question, or a question submitted in advance, wonders whether or not you think mycophenolate might be better in older patients compared to azathioprine. So we talked about MPO positivity, we talked about people who are not tolerant of cyclophosphamide or rituximab, people who have no major organ involvement. So Alvise, what do you think about using mycophenolate in the older patient in preference to azathioprine? Do you think there's a role for it there?
Oh, well, I mean, again, we have more evidence for azathioprine than mycophenolate. So in general, unless there are kind of some issues, I would start with azathioprine after rituximab for maintenance of remission. But that said, I think it's difficult to separate this clinical feature and say, okay, maybe it might be better for older patients instead of the younger, because again, MPO ANCA positivity goes with age. So elderly patients are more often ANCA positive, and they usually receive a diagnosis of MPA as compared to GPA, and so on. So these epidemiological features are really interacting with each other. So it's not really easy to separate one from the other. It happened anyway in my clinical practice to use it, but I wouldn't prefer mycophenolate over azathioprine or over rituximab just because of the age.
Yeah, okay. So age would not come into your decision making.
It's one of the things, but should be really balanced with other features.
Okay, so two more questions. If you're using mycophenolate, how long should you continue it? Would you continue it for the sort of 18 months, 24 months like you would with other maintenance therapies? Would you continue it for less time before you would start to, longer time before you start to taper it? Let me ask you, Andreas.
So this is, of course, not easy to answer. I think this is a general principle question. As Rachel alluded to, the REMAIN trial randomized patients to long-term azathioprine, and the control arm was actually, or they had the discontinuation of azathioprine. What it showed, and you would expect that the longer you treat, the lower your relapse risk. So basically, in my practice, maintenance duration is usually 24 months, and then I would taper it off. But of course, you can expect more relapses, especially if patients are BR3 ANCA positive. For the MPO ANCA positives, some are even only giving induction therapy. And if MPO ANCA is negative, they are not giving any maintenance therapy. So this is really individualized, and everyone has a different strategy. But I think 24 months is a good time to stop treatment and see what's happening afterwards.
Okay, so we're running out of time. So does anybody feel strongly that they have a different answer to Andreas? No.
No.
Annette, yes? Do you?
No. I think I always tell people that it's good to taper it once. Then they can show their true face, the patients, to see what phenotype they are. If they're the relapsing kind, you know that they are. You have to treat them differently.
Okay, and so just in response to Dr. Perez, you can see the session again. She's asking if it's recorded. It is recorded, and if you're an ERA member, you can watch it on the YouTube channel on the website. Okay, so final question: to plasma exchange or not to plasma exchange? Rachel, Yes or no, and when would you use it if you would?
It's definitely still there, and as one of the therapies I would go to for sure. I think the Pexivas study has shown that it doesn't have a huge effect in terms of efficacy, but I really think there's going to be subpopulations in whom there is a benefit. It's got to be weighed up against infection risks, and this is where there are pros and cons. But I think if you've got someone with rapidly deteriorating kidney function, where other therapies are failing, then I would start plasma exchange. I would also consider it upfront with other therapies in patients, certainly with a GFR less than 15 and potentially a GFR less than 20 to 30 as well. So yeah, I mean, if RPGN, yes, I would use it, especially if kidney function failed to stabilize or improve with other treatments.
Perfect. Alvise, would you use plasma exchange?
So I will answer from a rheumatology perspective.
Yeah.
Probably I will be a little bit more careful in using it. Of course, there are situations in which it's going to be used, needs to be used. But again, it's really important to stress that should be balanced against the infection risk. That's really important. If we are talking about a severe renal disease, but we do not have evidence to recommend it for alveolar hemorrhage. I guess this is important to stress it, since this was one of the things that was mentioned in the previous EULAR ERA guidelines. So,
thank you. Andreas, plasma exchange, yes or no?
Well, I'm a nephrologist, so yeah, I love plasma exchange or extracorporeal therapies. I think there is still a lot of unanswered questions, and as Rachel and Alvise said, the risk of severe infections, especially if you have untrained personnel in the apheresis unit, is high. You need to care for this patient. You need to give them good prophylaxis. But I think most of the patients would have a benefit, at least short term, if they present with a creatinine over 5.7, so equivalent to 500 micromoles. And I'm also pro plasma exchange in those with pulmonary hemorrhage. There has been an abstract presented in the ANCA and vasculitis workshop recently, although not significant, but there is a trend and numbers are generally small. So you have a huge confidence interval. But it showed a 50% reduction. We can't ignore that. And that's important. But I think, one of the most important things is that when you use plasma exchange, when you use cyclophosphamide plus rituximab, and that was mentioned by Rachel, you should limit your glucocorticoid exposure. That's a very, very important message, I think.
Okay, so 3 thumbs up for plasma exchange. Annette, is it a 4?
Yeah, right. So no, but I think that, well, there was this old trial called MePEX, and we have never changed since then. It's basically the same idea. There's people with severe kidney disease and also actually with alveolar hemorrhage, because, but using the dosing of glucocorticoids of Pexivas, which we hope will limit infections to at least a certain extent.
Superb, and that's taken us beautifully up to the hour. So I'd just like to thank again our speakers for introducing a really interesting topic today, and our panelists for some really stimulating and varied, helpful discussion. So I hope the ERA viewers enjoyed that. Thanks again also to the behind the scenes organisers at the ERA and at NDT, and also to my co-moderator, Dr. Stevens in Glasgow. You will receive some electronic feedback. Please fill this in. We're very keen to make these sessions as interesting and helpful for you as we can. You can find this paper in the December 2021 edition of NDT, published online just the end of last year. You can also tweet us and let us know what you think of the ERA journal clubs. For this paper, tweet is @NDT Social. And please join us at the next ERA Journal Club, which will be chaired by Dr. Will Harrington on the 26th of May. So that's it from us. Thanks and have a nice evening.